We can start?
Just wait. Yeah. You can start.
Let's start.
Good evening, everyone. Warm welcome to National Online ISA meeting. These classes are usually held on Monday or Tuesday at 6:30 p.m. I am Dr. Yashashwini, currently working in Medicover Hospitals, Visakhapatnam, as a senior resident in anesthesia and critical care. In today's session, we'll be discussing about anaphylaxis in the case discussion. And all this discussion will be happening in the today's class. But before we commence with the online class, let us invoke the divine blessings of Goddess Saraswati with the help of Saraswati Vandana. I may now request our Honorary Secretary of ISA National, Dr. Sukhminder Bajwa sir, to address the audience. Over to you, sir.
Thank you, Dr. Yashaswini. Today's class actually is one of the out-of-the-box class. Many times, I think over the years when we practice, we definitely come across this phenomena, the anaphylaxis during perioperative period. It can be preoperative, intraoperative, or even postoperative. So the history, the pre-anesthetic checkup, the history taking is very, very important component. Many times when you ask for the family history, you will come across that allergic processes in the family, prevalent in the family, or any personal history also. You say if you come across certain allergic phenomena happening previously, even your induction agent, the propofol, is the most allergen if you think from the induction agent side. And there are many other drug interactions also. So the history taking is very, very important. And the diagnosis, intraoperatively, is the most difficult one because at that time there are so many things happening. The surgical complication, the anesthetic complication, so many things can happen. It's a very difficult to diagnose immediately. But these cases, the discussion today will definitely bring us many differentials also, the preventive measures, then the treatment methods, interventions, and the differential diagnosis, how to treat them at that particular junction with the quick decision making. So this makes the crux for this particular class. It's a very challenging class. It's not that easy. So we have got a very good team today. So I request Dr. Yashaswini to introduce our faculty today.
Yes, sir. Uh, Coming to the faculty today, sir, I would like to invite Dr. Naveen Kumar, sir, who is a professor and HOD of Anesthesiology, working in Government Medical College or Government General Hospital, Anantapuram, Andhra Pradesh. He has a teaching experience of around 25 years and he is a awardee of COPS Award 2 times and State Award 2 times and has done 9 publications. Coming to the second moderator, sir, he is Dr. Jagadisha Charlu, sir. He is working as Associate Professor and Department of Anesthesiology in Government Medical College and Government General Hospital, Anantapuram, Andhra Pradesh. He has a teaching experience of 15 years and has done 9 publications, sir. And I would like to invite the moderator, Dr. Shaini, ma'am, and the students to take over the session, sir. Over to you, ma'am.
Dr. Shalia, you can introduce the students on behalf of Dr. Naveen Kumar, sir.
Good evening, everybody. Sir, I thank everybody for this great opportunity, sir, Bajwa sir and Madhuri ma'am. I would like to introduce my PG, sir, Mr. Sudhir Kumar, sir, and Dr. Gautami. Both are second year PG residents from our college, sir. Sudhir, you can start the topic.
Evening, everyone.
Sudhir, just a minute. 1 minute. Sudhir, just a minute. Sir, Sukuminder, sir, I want to talk for 1 minute, sir. To permit.
Yeah, please, sir, please.
Okay. First of all, I like to thank you for giving our PGs opportunity to present it. In our institutions, mostly anaphylaxis cases come for emergency cesarean section. The experiences we have shared today is also, they will post immediate after severe anaphylactic shock. They don't give us the time for stabilization also. Immediately they shift the case to the UOT, emergency OT for emergency cesarean section. This is a very, very challenging task, sir.
I think sir's
sir
connection got lost.
Sir is offline. Sir is
But I think this is the best way that sir maybe wanted to describe the amount of the cases, the amount of the clinical load in the hospital, and that to anaphylaxis. I think we are in the best, we are in the best institution where we can really find a real, a type of management in hand, the most customized management of such cases. I think we are lucky to have the class today. So, Dr. Sudhir, I think you can go ahead with the class now.
If it is possible, just a second, sir. I would like to discuss the rules for the today's class. So
Yeah,
I would
please.
request everyone to mute their videos and switch off, mute the audio and switch off the videos. And if any queries anyone are having, they can just drop it in the chat box and I'll be answering them. So if anyone are having any queries, please put it in the chat box and I'll be immediately answering them. Over to you, ma'am.
Yes, Sudhir, you can start the
Yes,
class.
Good evening, sir and ma'am. Today I am going to explain the topic of anesthetic management of a patient with severe anaphylaxis. Coming to contents of topic, history, definition, pathophysiology, investigations, complications, management, pre-op assessment, anesthetic implications, follow-up, and case scenario. And coming to history, Nobel laureates Charles Robert Richard Paul Portier coined the term anaphylaxis in 1902. It is a Greek word. Ana means again, phylaxis means protection. They observed fatal reaction in dogs where they re-exposed to C. anemones toxins, which was thought to be protective but instead caused hypersensitivity. In ancient Egypt, a report described the king Pharaoh's sudden death after a vaccine in hieroglyphics from 2640 before Christ. Coming to definition of anaphylaxis, it is defined as any acute life-threatening hypersensitive disorder and generalized rapidly evolving multisystemic allergic reaction. Any acute onset of it is also defined as any acute onset of illness with the typical skin features like urticarial rash or erythema, flushing, and or angioedema, plus involvement of respiratory and or cardiovascular and or persistent severe gastrointestinal symptoms. Can also be defined as any acute onset of hypotension or bronchospasm or upper airway obstruction, where anaphylaxis is considered possible even if typical skin features are not present. So, from this definition, not all anaphylactic reactions are present with skin features. Even without skin features, anaphylaxis may be present. The criteria of anaphylaxis: sudden onset and a rapid progression of symptoms, life-threatening airway and/or breathing and/or circulatory problems, skin or mucosal changes like flushing, urticaria, angioedema, erythema, and pruritus. The clinical manifestations of anaphylaxis include hypotension, tachycardia, shortness of breath, wheezing, high peak inspiratory pressures, bronchospasm, hypoxemia and decreased oxygen saturation, decreased breath sounds, angioedema, urticaria, itching, and flushing.
So we have prepared some questions for the audience, ma'am. So they can type the options in the chat box. So first question is, which of the following is not an early sign of anaphylaxis under anesthesia? So option A is sudden hypotension. Option B is decreased end-tidal CO2. Option C is raised airway pressures. Option D is bradycardia. Please type your options, answers in the chat box.
We have got an answer D from Dr. Ravi Kumar, Dr. Arnav, and Janara. Wait. Give them some time. Give them some time, doctor. Yeah, you can discuss that answers. Yes, you can discuss the answers. Dr. Sudhir?
The answer is option D, ma'am, bradycardia. So initially we'll be seeing hypotension and tachycardia, whereas bradycardia will be seen in the late stages when there is a complete cardiovascular collapse. That stage only we'll be seeing bradycardia. And all the remaining options will be seen in the early stages of anaphylaxis.
Coming to grading of anaphylaxis, it is adapted from Ring and Mesmer grading scale. Why we have to discuss grading is the treatment part changes according to each grade. Grade 1 includes generalized mucocutaneous signs like erythema, urticaria, angioedema. Grade 2 is multi-organ manifestations like mucocutaneous signs, bronchospasm, moderate hypotension. Grade 3 includes severe life-threatening multi-organ manifestations like arrhythmias, cardiovascular collapse, bronchospasm, may have cutaneous signs. Grade 4 is cardiopulmonary arrest, as it would treat according to SLS guidelines.
And the second question for the audience, what is the mechanism of anaphylaxis? Mechanism of anaphylaxis primarily involves which type of reaction? Type A is type 1, type 2, type 3, type 4. So please type your answers in the chat box, sir.
Dr. Ravi Kumar, Dr. Nagnath, and Vaishnavi. Yeah, we have a lot of answers of answer A. I would request everyone to answer for the MCQ.
The answer is option A, type 1 hypersensitivity reaction. It's good to see that everybody answered the correct answer. Usually type 1 hypersensitivity reaction, it is IgE mediated, is the most common mechanism of anaphylaxis. Continues.
The Now let's discuss the pathogenesis of anaphylaxis. It is a type 1 hypersensitivity reaction. The mechanisms include immunological and non-immunological. In immunological, IgE-dependent, IgE-independent mechanism. In IgE-dependent mechanism, when there is exposure to foods, allergens like insects in latex drugs, there is initial exposure to antigen causes sensitization. The antigen presenting cell present the antigen to the T helper cells. These T helper cells stimulate the B cells to differentiate into plasma cells and produce the IgE antibody against antigen. The IgE antibodies binds to FcRA receptors and mast cells and sensitizing them to the antigen. On re-exposure, the antigen causes cross-linkage of IgE, FcRAs and mast cells. The final step occurs, that is inappropriate mast cell activation. In immunological IgE-independent mechanism, there is direct activation of complement pathways. Non-immunologic mechanism like physical stimuli like exercise, heat, cold, sunlight causes mast cell activation. This mast cell activation occurs in two phases, that is immediate phase and late phase. Immediate phase occurs within seconds to minutes and causes degranulation of mast cells and release of preformed mediators like histamines, prostaglandins, leukotrienes, platelet activating factors, tryptase, tumor necrosis factors. This causes systemic manifestations like vasodilation, increased vascular permeability, smooth muscle contractions, and increased mucus secretion. Late phase occurs in minutes to hours. This late phase is the cause for occurrence of biphasic reactions. Coming to pathophysiology of anaphylactic shock, it is due to inadequate tissue perfusion, secondary to hypoxia and hypotension. Hypoxia is due to airway edema, bronchospasm, and reduced pulmonary blood flow. This reduced pulmonary blood flow due to reduced cardiac output and reduced venous return. These occurs due to manifestations of inflammatory mediators, causes fluid extravasation and vasodilation. Coming to differential diagnosis of anaphylaxis, first one is foreign body aspiration. How we differentiate it from anaphylaxis? In foreign body aspiration, there is history of exposure to soot particles, eating, playing objects like. In anaphylaxis, there is history of exposure to allergen. In foreign body aspiration, there is a stridor, localized wheeze is present. In anaphylaxis, generalized wheeze is present. In foreign body aspiration, onset is sudden and cough is a prominent symptom. In anaphylaxis, cough is not a prominent symptom. In anaphylaxis, skin features are present. In foreign body aspiration, skin features are absent. Next, second one is vasovagal reaction. It is a benign reflex mediated reaction, causes sudden drop in blood pressure and heart rate. Any trigger like fear, emotional distress, sight of blood causes vagus nerve stimulation, causes bradycardia, whereas anaphylaxis tachycardia is present. Next one is vocal cord dysfunction. It is a functional breathing disorder. There is paradoxical tightening of vocal cords during inhalation. In this, skin changes are absent. In anaphylaxis, skin changes are present. Next one is severe acute asthma. It is an isolated lower respiratory distress without skin changes and hypotension. In anaphylaxis, skin changes, hypotension will be present. Coming to pulmonary embolism, it is obstruction of pulmonary blood flow by the thrombus. In anaphylaxis, it is a history of exposure to allergen. In pulmonary embolism, tachycardia will be present and crackles, decreased breath sounds will be present. In anaphylaxis, stridor, wheezing will be present. Whereas anaphylaxis is a distributive shock and pulmonary embolism is an obstructive shock and skin changes are absent in pulmonary embolism. Other differential diagnoses are acute anxiety, myocardial dysfunction, acute poisoning, hypoglycemia, and seizures. Coming to investigations, diagnosis of anaphylaxis is primarily based on symptoms and signs. It is a clinical diagnosis. Laboratory investigations are initially not useful because it takes time to process and gives false positives and false negatives. The investigation we done in anaphylaxis are serum tryptase, serum histamine, skin test, serum IgE levels, and basophil activation test. Into complications of anaphylaxis, hypoxemia, hypotension, end organ dysfunction, cardiovascular collapse, respiratory failure, and death if untreated.
Question for the audience. Which of the following is not a mediator involved in anaphylaxis? Option A is serotonin, option B is histamine, option C is tryptase, and option 4 is leukotrienes. Please type your answers in the chat box.
You can just keep on repeating the options. Yeah.
Option A is serotonin. Option B is histamine. Option C is tryptase. And option 4 is leukotrienes.
Yes. I think maximum people have gone in for A.
Yes.
So what is the right answer?
The correct answer is A, ma'am, serotonin.
Okay. So
it
the
is not a
audience has
mediator.
got it right. Go ahead.
Yes.
Coming to management of anaphylaxis, the general measures include immediate withdrawal or stoppage of the culprit drug. If not, if we start any antibiotic infusions, we stop the infusions, and reducing the depth of anesthesia if surgery has started. In essence, reducing the depth of anesthesia means if eliminating the harmful agents like volatile agents, it has a potent vasodilatory and myocardial depressant effect. It worsens the anaphylaxis. And use of Trendelenburg position or leg raising maneuvers to improve venous return and improve the cardiac output to restore blood pressure, and call for help early for multidisciplinary action. The immediate measures include resuscitation with IV fluids. Adrenaline is the mainstay of treatment, and securing the airway. Airway management is of paramount importance. Perioral edema, stridor, and angioedema are the risk factors for securing the airway. Obtaining a definitive airway is imperative. Gentle laryngoscopy during intubation should be advised. Delay in securing the airway may reduce the chances of successful intubation as continued swelling occurs, increasing the risk for a surgical airway like emergency tracheostomy and clipothyroidotomy. Volume resuscitation plays an important role in anaphylaxis. Up to 73% of blood volume may extravasate into the interstitial space within 15 after the onset of the event. Around 3 liters of plasma volume is extravasated into the interstitial space. Steroid will be given 20 to 30 ml per kg. Adrenaline is the cornerstone of management. Priority of the treatment is the restoration of mean arterial pressure more than 60 mm of mercury, which maintains the perfusion in vital organs. Epinephrine dose is based on the grading of anaphylaxis.
Question for the audience. Which IV fluid is preferred during anaphylaxis? Option A is 5% dextrose. Option B is normal saline. Option C is albumin. Option D is dextran solution, which is colloid solution. Please type your answers in chat box.
Can you repeat the options, Dr. Sudhir?
Option A is 5D, that is 5% dextrose. Option B is normal saline. Option C is albumin. And option D is dextran solution, it's colloid solution.
Good to see everyone answered. The majority of the answer is B.
Yes, the answer is correct.
Okay.
For preferred fluids are normal saline 0.9% NaCl and ringer lactate. Coming to adrenaline dosing according to each grade. In grade 1 and 2 anaphylaxis, the adult dose of adrenaline is 5 to 20 micrograms IV. Children's dose is 1 to 5 micrograms per kg IV. In grade 3 anaphylaxis, that is severe hypotension and bronchospasm, adult dose is 100 to 200 micrograms IV. Children dose is 5 to 10 micrograms per kg IV. In grade 4 anaphylaxis, that is cardiopulmonary arrest, the adult dose is 1 milligram IV. Children dose is 0.01 mg per kg IV. If intravenous access is not available, 10 micrograms per kg iron will be given up to maximum of 500 micrograms. Less than 12 years old, 300 micrograms IM. Less than 6 years old, 150 micrograms IM. If intravenous access is not available, intravenous intraosseous dosing not achieved, endotracheal administration of adrenaline also preferred. The dosing is 2 to 2.5 times more than intravenous dose. It should be diluted in 5 to 10 ml of distilled water to increase the absorption of the drug. The endotracheal administration, the drug is absorbed through the alveolar capillaries.
Question for the audience. What is the recommended adult IM dose of adrenaline in anaphylaxis? Option A is 0.3 mg. Option B is 0.5 mg. Option C is 1 mg. Option D is 5 mg. Please type your answers in chat box, please.
There are only 3 options for this.
4 options, ma'am. Option A 0.3 mg, ma'am. Option B is 0.5 mg. Option C is 1 mg. Option D is 5 mg.
Oh, the D is not seen. Okay. Yeah, now we can see it.
So the
Few people answered B and few people answered C. So what is the answer?
answer is B, ma'am. 0.5 mg, the IM dose. According to the latest Resuscitation UK Council 2021 guidelines, IM dose is 0.5 mg, ma'am, for adults. IM dose.
Yes. Dr. Shelia, please unmute yourself. We cannot hear you.
Coming to guidelines of Resuscitation Council 2021, these guidelines emphasize that airway, breathing, circulation, visibility, and exposure. After we suspect any anaphylaxis, first we call for help. After discussed earlier, remove the triggering agent. If lie the patient flat and trend back position to improve venous return. If patient is pregnant, we should keep them in left lateral position to reduce the aortic cable compression and improve venous return. These guidelines suggest the intramuscular dosing of adrenaline 0.5 mg IM, injected anterolateral aspect of middle third of the thigh, and establish airway, give high flow oxygen, and monitor vitals. If no response to first dose, and repeat IM adrenaline after 5 minutes and IV fluid boluses. In adults, 500 to 1000 ml will be given. In children, 10 ml per kg. If no improvement in breathing or circulation problems, despite 2 doses of IM adrenaline, we diagnose it as refractory anaphylaxis. The treatment of refractory anaphylaxis we discuss in next slides.
Question for the audience. What is the preferred route of administration of adrenaline in anaphylaxis? Option A is IM route. Option B is IV route. Option C is subcutaneous. Option D is A and B. Please type your answers in the chat box. Option A is IM route. Option B is IV. Option C is subcutaneous route. Option D is A and B.
So can we have the answer, please?
Yes, the answer is option D, ma'am, A and B. So based on scenarios, we divide whether we have to give IM or IV. For example, patient is in out of the hospital setting, and when there is no IV cannula available, and when there is no, when the treating physician doesn't know the IV dose, or when there is no closed hemodynamic monitoring, we'll prefer IM route, ma'am. Whereas IV route is preferred in case of perioperative settings in the presence of intensivist and anesthesiologist, or when IV cannula is patent IV cannula is available, and when there is closed hemodynamic monitoring. In these scenarios, we'll prefer IV route. So option A and B is correct.
Coming to second line of management, as we observed, many people tend to give antihistamine steroids in place of adrenaline. Thus, delays the administration of adrenaline. This use of antihistamines is associated with occurrence of biphasic reactions. They are not recommended for the initial treatment of anaphylaxis. Can be used to treat skin symptoms. Examples are injection diphenhydramine 0.5 to 1 mg per kg IV or 50 to 75 mg IV. Injection ranitidine 1 mg per kg IV or 50 to 150 mg IV. Same goes with steroids also. Pre-hospital treatment with the corticosteroids was associated with an increase in rate of hospitalization and ICU admissions and morbidity. while this could be due to steroids being used in preference to adrenaline administration. Examples are injection hydrocortisone 2 to 4 mg per kg IV, injection methylprednisolone 1 to 2 mg per kg IV, injection dexamethasone 0.1 to 0.4 mg per kg IV.
Question for the audience. Steroids has specific role in which of the following conditions of anaphylaxis? Option A is acute anaphylaxis. Option B is patient with poorly controlled history of asthma. And option C is refractory anaphylaxis. And option D is both B and C. Please type your answers in the chat box, please. Option A is acute anaphylaxis. Option B is patient with poorly controlled history of asthma. Option C is refractory anaphylaxis. Option D is both B and C.
Majority of the people answered with D, and we have an answer of B. I would request all the participants to answer for the MCQ.
The correct answer is D, both B and C. So steroids has no role in acute anaphylaxis, and literature says the steroids has a beneficial role in patients with asthma history and in patients with refractory anaphylaxis. In these two conditions only, steroids has specific role.
Treatment of persistent bronchospasm. Adrenaline infusion remains the cornerstone of treatment. Beta-2 adrenergic agonist salbutamol 2.5 to 5 mg can be administered through the inhalational route. If resistant to inhalational route, consider IV salbutamol 100 to 200 micrograms bolus, followed by a continuous infusion at 5 to 25 micrograms per minute. IV magnesium is not recommended because it is itself causes hypotension. To refractory anaphylaxis, as we discussed earlier, the definition of refractory anaphylaxis is if there is no improvement in cardiovascular or respiratory problem despite 3 appropriate doses of IV adrenaline and 2 doses of IM adrenaline. Causes of refractory anaphylaxis include there is ongoing release of inflammatory mediators and insufficient adrenaline dose, delayed administration of adrenaline, and failure to discontinue the culprit drug, failure to reduce or discontinue the maintenance anesthetic drugs. The treatment of refractory anaphylaxis include adrenaline infusion at 0.05 to 0.1 mg per kg per minute. If refractory to adrenaline infusion, alternative vasopressors are added. Noradrenaline infusion started at 0.05 to 0.5 mg per kg per minute. Vasopressin bolus dose is 1 to 2 international units. Infusion dose is 2 international units per hour. Metronidazole, it is a sympathomimetic alpha-1 agonist. It acts on smooth muscles of blood vessels and used in acute hypotension. Bolus dose is 0.5 to 1 mg IV. Infusion dose is 0.05 mg per kg per hour. If patients on beta blocker therapy, glucagon could also be effective. Dose is 1 to 2 mg IV, repeated every 5 minutes. It directly acts on heart and increases contractility. The guidelines for refractory anaphylaxis. This guideline suggests the adrenaline infusion. First, we give IM adrenaline every 5 minutes until the adrenaline infusion has been started. How do we prepare it? 1 mg adrenaline in 100 ml of 0.9% sodium chloride and started at a rate of 0.5 to 1 ml per kg per hour and titrate according to the clinical response. Continue the adrenaline infusion and treat the airway breathing circulatory symptoms and titrate according to the clinical response. Give high flow oxygen, titrate the saturation to 94 to 98% and monitor vitals. And oxygenation is more important than intubation. If apneic, patient is apneic, bag and mask ventilation and consider tracheal intubation. And IV fluids are given in children 10 ml per kg bolus, in adults 500 to 1000 ml bolus. And place arterial cannula for continuous BP monitoring and establish central venous access. If refractory to adrenaline infusion, consider second line vasopressors. If cardiac arrest, follows the ALS algorithm. And duration of surveillance needed following anaphylaxis is If there is good response to a single dose of adrenaline and complete resolution of symptoms, and there is adequate supervision following discharge, we observe for 2 hours. If 2 doses of IM adrenaline needed to treat reaction or previous biphasic reactions are present, we observe for 6 hours. If severe reaction requiring more than 2 doses of adrenaline, or patient has severe asthma or reaction causing severe respiratory compromise, or patients in areas where access to emergency care is difficult, we observe for 12 hours. Into prognosis, with rapid and adequate treatment and monitoring, the risk of morbidity and mortality is low. As we discussed earlier, the administration of antihistamines and steroid delay the administration of adrenaline. Failure to treat anaphylaxis promptly with epinephrine may result in biphasic or protracted anaphylaxis. The overdose of adrenaline also causes the pulmonary edema, ventricular dysarrhythmias, myocardial infarction, cerebral hemorrhage, and death. With proper dosing and monitoring, we can avoid these complications.
Question for the audience. Patient is suspected to have anaphylaxis and his clinical features are urticaria, angioedema of lips, and generalized edema. So, what is your initial treatment of choice? Option A is antihistaminics. Option B is steroids. Option C is adrenaline. Option D is IV fluids. Please type your answers in the chat box, please. Option A is antihistaminics. Option B is steroids. Option C is adrenaline. Option D is IV fluids. Please answer in the chat box, please.
I think some people answered C and some came up with an answer of A.
So the correct answer is option C, adrenaline. So even in case of grade 1 and grade 2, we prefer adrenaline as initial line of management because the grade 1 may progress to grade 2, it may progress to grade 3. So the initial choice should be adrenaline. So right answer is C, adrenaline. So now let's discuss about the pre-op assessment of a patient with history of anaphylaxis. So coming to history, first we need to note down details about the anaphylactic episode regarding a trigger, the allergen. So we should identify the causative agent, whether it was a drug, whether it was a food item, or whether it was a contrast agent, or it was latex. And coming to date and severity, the time seems the last episode of anaphylaxis and severity, whether it was mild or moderate or severe in nature. And we should note down the circumstances during which the anaphylaxis has occurred, whether it was out of the hospital setting or in the hospital setting. So we should note down. And coming to treatment required, we should know whether the patient required adrenaline and if required, how many doses of adrenaline patient needed, and whether patient needed airway management. That means whether a patient intubated and kept in ICU. We should note down. Coming to outcome, the recovery time for the patient, how many days he was admitted in ICU, we should note down. Now coming to allergic history, so we should know the known allergies of the patient. Either patient is allergic to some drugs or pollen or environmental allergies or dust allergies, and we should look for any cross reactivity risk. That means, for example, if patient is allergic to some penicillin group of drugs, then he might be allergic to cephalosporins. So this is called cross reactivity risk. So it occurs because of the R group side chain. For example, if patient is allergic to one type of muscle laxant, then he might be allergic to another type of muscle laxant. This is called cross reactivity risk. And we should know the history, if there is any family history of atopy or asthma allergies running in the families, and then past medical and surgical history. And we should know if patient is having any coexisting diseases like asthma, atopy, and any cardiovascular diseases, because patients with cardiovascular diseases may not tolerate the severe hypotension, severe tachycardia occurring during anaphylaxis. And we should note down if there were any previous anesthetic exposures and the tolerated drugs by the patient, and there was any past history of anaphylaxis during surgery, and what drugs he was treated, and we should refer the charts. Coming to drug history, we should know the regular medications taken by the patient. Now, apart from that, we should concentrate on especially patients taking beta blockers and ACE inhibitors, because patients who are taking beta blockers, ACE inhibitors, if anaphylaxis occurs in them, so they are resistant to adrenaline, because since adrenaline acts on beta 1 and beta 2, so in patients taking beta blockers, this adrenaline effect on the beta 1 inotropy and beta 2 bronchodilation will not be seen. So making the patient resistant to adrenaline. So requiring more dose of adrenaline or requiring glucagon. Same goes with ACE inhibitors. Patients with on therapy of ACE inhibitors, if patients diagnosed to have anaphylaxis, so these patients will be having bradykinin mediated symptoms like more severe angioedema and more profound hypotension. So these two drugs we should concentrate during history taking. Coming to review of systems in case of emergency surgery, coming to respiratory system, we should look for if there is any wheeze, and we should look for asthma, whether it was controlled or not. And coming to CVS examination, if there is any hypotension, arrhythmias, and if there is any MI, occurrence of MI post anaphylactic episode. Coming to skin examination, we should look for urticaria, angioedema, and eczema. Coming to examination, if posted for emergency surgery. So coming to general examination, we should look for if there is any airway swelling. It might be indicated by stridor, and if there is rash, mucosal lesions. And coming to airway, if there were any signs of previous airway compromise, that means if patient had any previous anaphylactic episode, and if there is severe angioedema or submandibular edema and severe edema of the airway, he might be intubated, or he might be undergone tracheostomy or scalpel cricothyroidotomy. So we should look for any scars in the neck. Because of history in the examination part. And coming to respiratory system, we should auscultate for any wheeze. Coming to CVS, we should record the heart rate and BP. Coming to investigations, if patient posted for elective surgery, apart from the routine pre-op tests, we should also look for some allergy tests like skin prick test or intradermal test. This test is used to identify the causative agent and the mechanism involved, whether it was immune mediated or non-immune mediated, and the culprit agent involved. And then serum specific IgE test should be done. And this test is available only for some drugs like neuromuscular blocker agents, opioids, and latex. And then drug challenge test or drug provocation test. So if the patient is negative for skin prick test and negative for serum specific IgE test, then we can go for a drug challenge test. And it was considered as the gold standard test for allergic testing. And in this test, we gradually give the increased doses of suspected drug to the patient and look for reactions. And this drug challenge test should be done in the presence of multidisciplinary approach. Coming to anesthetic implications, why the anaphylaxis is more important? What is the significance means for the anesthesiologist? This represents a very high risk scenario because of two reasons. One is many anesthetic agents we use intraop may trigger or worsen the anaphylaxis. So prompt recognition and treatment is of very important, and it involves the main systems in our body, CVS and RS systems. And we should avoid the triggers. If patient posted for emergency surgery, like we should make the environment latex free, and we should make the chlorhexidine free preparation. And if we know the patient is allergic to some drug in charts, then we should avoid that specific drug, and we can choose safe alternatives. If patient is allergic to ester local anesthetics, we can go for amide local anesthetics. And the question for the audience: in perioperative anaphylaxis, latex allergy is best prevented by option A is pre-medicating with antihistaminics. Option B is avoiding latex gloves and catheters. Option C is using low-dose steroids. Option D is avoiding IV fluids. Please type your answer in the chat box, please. Option A is pre-medicating with antihistaminics. Option B is avoiding latex gloves and catheters. Option C is using low-dose steroids. Option D is avoiding IV fluids. So many of you have answered option B. So option B is the right answer. So best way is to prevent anaphylaxis is to avoid that suspecting agent. And coming to pre-medication, we can consider H1 blockers like diphenhydramine, cetirizine, and steroids like hydrocortisone preoperatively. But the evidence is very limited, but can be useful in case of high-risk cases like patients with history of poorly controlled asthma. And we can avoid sedatives causing histamine release like morphine and pethidine intraoperatively. And we should be prepared for the emergency situations. That means the anaphylaxis tray should be kept ready with 1:1000 and 1:10,000 dilution prepared adrenaline. That means 1 ml, 1 ampoule contains 1 ml of adrenaline contains 1 mg. That is 1:1000 dilution. And if we take that 1 ml and dilute to 10 ml, it becomes 1:10,000. That means each ml contains 100 mics. So these two should be kept ready. And IV fluids, oxygen, airway equipment, 20% intralipid. If local anesthesia allergy suspected, these should be kept ready. And adrenal infusion should be set up if there is a history of previous severe episode of anaphylaxis. Coming to intraoperative implications, for induction agents, we should use non-histamine releasing agents. For example, induction agents like etomidate, ketamine, and benzodiazepines are preferred. And coming to propofol, literature says if even patient is having egg allergy or soybean allergy, we can give propofol. But if there is any documented history of anaphylaxis to propofol, then only we should avoid propofol. Then coming to opioids, fentanyl, remifentanil can be given, and we should avoid morphine. Coming to muscle laxants, vecuronium is preferred, and we should avoid succinylcholine, rocuronium, mivacurium, atracurium, cistadracurium because these agents cause more allergic reactions. And coming to inhalation agents, we can go for sevoflurane for induction and maintenance of anesthesia. Coming to monitoring, standard ASM monitoring should be followed, and we should consider invasive BP monitoring if the case is high risk or if there is a major surgery. And we should continuously monitor for early signs of anaphylaxis like any hypotension, tachycardia, and bronchospasm, increased airway pressures, and increased resistance to cerebral bag while giving positive ventilation, and cutaneous signs like flushing, rash, facial edema, and desaturation and difficulty in ventilating. The drugs which should be avoided, these are the histamine-releasing drugs, like induction agents like thiopental sodium, and opioids like the morphine, pethidine should be avoided, and muscle laxants like the succinylcholine, atracurium, mivacurium, and rocuronium should be avoided. And antibiotics like beta-lactams should be avoided if patient is already allergic to penicillin type of antibiotics. And antiseptics, chlorhexidine should be avoided. And fluids like gelatins, dextrins, these are colloids, these should be avoided. Coming to post-operative care, observation should be done for at least 24 hours in post-anesthesia care unit or high dependency unit. And adrenaline, fluids, oxygen should be kept ready in PACU units because sometimes biphasic reactions may occur. Initially, after resuscitation, symptoms, signs, and will resolve completely. But after 12 to 24 hours, they may again come. This is called biphasic response. And it may occur due to initial inadequate treatment or the late phase of release of mediators. So these two are the main causes of biphasic reactions. So we should be ready. So that's why observation is more important after resuscitation. And we should document the intraop exposures for future reference. Whatever the drugs patient has exposed, we should document that. And we should educate the patient regarding the anaphylactic episode that occurred in the OT and how he was treated And we should issue him a allergy card enlisting all the unsafe agents so that he will avoid them in the future. And we should, as I have already said, we should watch for biphasic response. And this is a flowchart explaining about a patient with suspected perioperative allergic reaction or unexplained perioperative reaction, which has not been investigated. So if patient posted for emergency surgery or urgent elective surgery or non-urgent surgery, if patient posted for emergency surgery, so first we should gather any relevant charts. If the patient is having any charts regarding the drugs which he is allergic, if the information is available, then we should avoid all the drugs patient is allergic and we should use alternative drugs. And if there was no information available, then it is safe to use some regional anesthesia technique and we should use only few drugs possible and we should avoid neuromuscular blocking agents and we should avoid latex and disinfectants like chlorhexidine. And if antibiotics are used or indicated, we should avoid the penicillin and cephalosporin groups and we should have high suspicion and we should have a vigilant monitoring for early signs of anaphylaxis. If patient posted for urgent elective procedure also, it goes same. You should look for any charts. And if patient posted for non-urgent surgery, that is elective surgery, then we should look for charts related if allergy is suspected. And if it is allergy is ruled out, then we can proceed with routine anesthesia. And if there was no information available, then it is better to postpone the surgery and refer the patient to allergy clinic and for further follow-up. And coming to selection of anesthesia technique, as I have discussed, if posted for elective surgery, we should defer the case. If posted for emergency surgery, securing the airway and continuing DJ is preferred technique. And let's discuss the outcomes after perioperative anaphylaxis. So in recent studies, it was noted that in patients with grade 3 reactions, if the patient is adequately resuscitated, there are no complications, even if the surgery is continued or abandoned. Whereas in patients with grade 4 reactions, grade 4 is cardiopulmonary arrest. So there were higher chance of complications if we proceed with the surgery in grade 4 reactions. Coming to follow-up in the allergy clinic, it is very essential and it is serves to establish whether anaphylaxis has occurred or not, and we can identify the underlying mechanism, whether it is immune mediated or non-immune mediated, and we can identify the culprit agent involved in the anaphylaxis, and we can also identify the safe alternatives which can be used in the future, and we can provide explanations and reassurance to the patient, and detailed report can be given for future advice for anesthetics. The tests performed are the serum histamine and tryptase, skin prick test, and then serum specific Ig levels and basophil activation test. The question for the audience: which of the following test is least useful in diagnosing anaphylaxis after initial 24 hours? Option A is serum histamine. Option B is serum tryptase. Option C is skin prick test. Option D is none. Please type your answers in the chat box, please. Option A is serum histamine. Option B is serum tryptase. Option C is skin prick test. Option D is none.
I think majority of the people answered A and some people answered B.
Yes, ma'am. The correct answer is option A, serum histamine, ma'am. So serum histamine has half-life of around 15 to 20 minutes, ma'am. So it should be measured within initial 30 minutes. So after 24 hours, it has no role, ma'am. Coming to serum histamine test, it is a preformed mediator produced by basophils and mast cells, and its normal value is less than 10 nanomoles per liter. and its half-life is 15 to 20 minutes. And so it is preferably measured within 30 minutes of onset of anaphylaxis. Coming to serum tryptase, its normal value is 11 to 13 micrograms per liter, and its half-life is around 90 to 120 minutes. And for serum tryptase, we should take 3 samples. One should be taken at within 1 hour after onset of anaphylaxis. Second sample is at 2 to 4 hours, and third sample is at 24 hours. And we should compare the acute elevations. That means sample taken at 1 hour and 2 to 4 hours should be compared with the sample taken at 24 hours or the next day following during follow-up. And a level of above 1.2 times of baseline value plus 2 micrograms per liter is considered to be indicative of mast cell activation. Coming to skin test, as I have already said, it is used for the identification of the culprit agent and the mechanism involved in the safe alternatives. And the culprit agents and the cross-reactive drugs which were identified in the skin testing should be avoided, while the negative tested drugs can be safely given. And let's discuss a case scenario which we have resuscitated in our hospital. Was like a 25-year-old multigravida with gravida 3 para 2 live 2 with 36 weeks with scar tenderness. She has been posted for emergency LSES. As a part of preoperative preparation, patient was given injection cefotaxime as a test dose on her right forearm in labor room. And immediately after 5 minutes, she developed generalized erythema, hypotension, tachycardia, dyspnea, chest tightness, and 2 episodes of vomiting. On examination, patient is conscious oriented and her blood pressure is 80 by 50 mmHg and her pulse rate is 130 per minute regular and low volume. Her saturation in room air is 74% and her respiratory rate is 35 per minute. And on RS examination, air entry is present, but there is bilateral wheeze noted. Patient was suspected to have anaphylaxis from the antibiotic given, that is cefotaxime. So resuscitation was started with IV fluids, normal saline 1 liter bolus, and patient is having intact patent IV cannula. So we gave adrenaline 100 mics IV bolus 2 doses, and injection hydrocortisone 2 mg IV and injection phenylamine 5 mg slow IV were given because of the cutaneous manifestations patient is having, and because of the bilateral wheeze, patient was given with nebulization salbutamol. And post resuscitations, her vitals were her BP was 150 by 90 mmHg and her pulse rate was 130 per minute. And her saturation was 92% with 10 liters of O2 through simple Hudson's face mask. And her respiratory rate is 30 per minute. Still, on respiratory system examination, mild wheeze was noted. On FHR monitoring, it was found to be 80 per minute. So it was diagnosed as fetal bradycardia. So for the above reason, the patient was immediately shifted to emergency OT. So since the patient is having still wheeze even after resuscitation, and to avoid further airway complications, to avoid further airway instrumentation, we chose to give her general anesthesia. We chose to give her regional anesthesia, that is TAP block, transabdominal plain block. So these are the intraoperative condition of the patient showing stable vitals. And let's discuss briefly about transversus abdominis plain block. It is a regional anesthesia technique used mostly for postoperative pain management in abdominal wall procedures. It provides somatic analgesia to the anterior and lateral abdominal walls. The anterior abdominal wall is composed of 3 muscles mainly: external-oblique, intra-oblique, and transversus abdominis muscles. The sensory innervation of the abdominal wall nerves comprises of spinal nerves from T6 to L1, and these nerves will present between the internal oblique and transversus abdominis muscles. Coming to anatomy, you should know about the iliac crest and subcostal margin and the 3 muscles. The nerves in the TAP compartment are the intercostal nerves, subcostal nerve, ilioinguinal nerve, and iliohypogastric nerve. The technique of TAP block is we should first identify the triangle of Petit by palpating the pelvic rim at the mid-axial line. And it was found by 3 boundaries. The inferior boundary is found by the iliac crest, and the anterior border is found by the external oblique muscle, and The posterior border is formed by the latissimus dorsi muscle. And while the patient lies in a supine neutral position, after proper identification of the boundaries and after proper preparation and draping, a short bevel regional block needle is inserted perpendicularly to the skin. After piercing the skin, two pops are felt. The first pop is caused by the facial extension of the extra-oblique piercing. The second pop is caused by the facial extension of intra-oblique piercing. After negative aspiration, the local anesthetic is injected. So we have successfully completed the cesarean section with the tab block with minimal sedation in our hospital settings. The take-home message in this class is the prompt recognition and treatment saves lives, and we should stop suspected trigger immediately, and we should resuscitate aggressively, and we should maintain vigilance for biphasic or delayed reactions. That's why observation is paramount importance even after resuscitation, and we should investigate thoroughly and confirm the diagnosis. And we should document everything clearly, and future anesthetic drugs must avoid this culprit agent, and we should educate the patient properly regarding the intraoperative events and the drugs he should avoid in the future. Team awareness is of very crucial. And the bottom line is preparation prevents panic. The three cornerstones of management of anaphylaxis are the vigilance, adrenaline, and documentation. These are our references. Thank you.
So thank you very much. Thank you very much to Anantapur team for that excellent presentation on perioperative anaphylaxis. So Dr. Yashaswini, just check if there are any questions in the chat box.
Yes, ma'am. We have a
And
couple
please
of questions,
tell us what
ma'am.
are those questions. Yeah.
Yes.
Dr. Sudhir and Dr. Shalia will be answering the questions.
Yes, ma'am. So, Dr. Muthukumar, he asked, what is the dose of intratracheal adrenaline through ET tube? Dr. Shalia, ma'am.
It is 2 to 2.5 times more than the intravenous dose, and we can dilute in 5 to 10 ml of distilled water. So it increases the endotracheal administration. The adrenaline is absorbed through the alveolar capillaries, and some amount may be lost in the endotracheal tube. So it is 2 to 2.5 times more than the intravenous dose.
Yes.
Okay. And another question by Dr. Kondareddy. What are the features that suggest patient under general anesthesia are having anaphylaxis?
Initially,
Can you repeat the question?
Yes, ma'am. What are the features that suggest that anaphylaxis of patient under general anesthesia?
Acha, features, clinical features. Okay.
Yes, ma'am.
So initially, the skin features will be missed, ma'am, because of the patient will be covered by the surgical drapings. So the hypotension will be unexplainable, ma'am. Even if you give pressors, the hypotension will not be cured. And then bronchospasm we can detect by while doing a positive pressure ventilation. There may be high peric pressures, and if you are doing manual bag and mask ventilation, there may be resistance to manual bag and mask ventilation. And yes, there might be desaturation or auscultation, wheeze, and decreased DTSO2. These are the signs seen during GM under anesthesia for anaphylactic patient.
Okay.
Yes. Any other question?
No, ma'am. As of now, everything is covered, ma'am. That's it.
Okay.
Only 2 questions.
Okay. So I have one question for you, Dr. Sudhir. So is there a role of methylene blue in the treatment of anaphylaxis? I'm not sure whether you mentioned about it, but is there any role of methylene blue in the treatment of anaphylaxis? Shall I add it myself? So IV anaphylaxis, when there is refractory anaphylaxis, they have tried using intravenous methylene blue, 1 milligram per kg. So 100 ml diluted in 100 ml of 5% dextrose given in the dose of 1 milligram per kg up to a maximum of 2 milligram per kg. So you know that in anaphylaxis, the main problem is the vasodilatation caused by nitric oxide. So this methylene blue, it will go and block this pathway. It will block that enzyme, no, guanylate cyclase. And the nitric oxide pathway is blocked. And because of that, the vasodilatation will come down. And that is how it is useful to treat the hypotension of refractory anaphylaxis. Mind you, this is not the first line treatment. The first line treatment is always adrenaline. This is just a second line, probably in refractory anaphylaxis. What is your say on that, sir? You want to add anything?
I will just Dr. Madhuri, because see, that was used a very long time back when it was an experimental stage.
Yeah.
So why they discarded it? Because you cannot make it sterile. You're putting into the intravenous compartment. The sterility itself was a question when it was rejected for that particular purpose. Yeah, I think it was ignited again for the methylene blue and other poisonings also. But all the question always remain about is sterility. Very difficult to maintain the sterility, although it comes in a while. But that's an industrial preparation. The medical preparation has not been up to the mark for the methylene blue. I think that's why it was out of the vogue. It was proposed at some time back, maybe 1.5 to 2 decades back, but not used nowadays.
Yeah, it's an experimental therapy only.
Yeah,
And it is
because the
known to
sterility
cause
was the
cardiac
question.
arrhythmias also. It is known to cause cardiac arrhythmias also. So it's just an experimental therapy in refractory cases.
And Sudhir, when I think you are facing a lot of clinical load of these patients, where you have seen the incidences of anaphylaxis, do you have a policy for this particular the consent form where you particularly imbibe this anaphylaxis word, where you give it something like bold in that particular consent anesthesia consent form, because you have been facing such problems, I think frequently, or you're getting in these cases more than I think the cases of from other hospitals. So, do you have a particular protocols to manage these cases preoperatively, consent form, postoperatively, and in the ICU also?
So, good evening, sir. I am
Yeah,
Dr. Naveen. We have included in consent itself, sir, the drug reaction to so and so drugs and any drugs and blood also. There no separate consent form is taken, but that line is included in the consent form.
that is very important part, because when you are dealing
You
with
have
it, because
included.
yeah, because our usual consent forms don't take them as they are generalized form basically. So I think that line should be there with anaphylaxis happening so frequently and reported less frequently. That is very, very important. Okay, I think the class was wonderful, and you people presented something good case presentation. And anyway, it will remain imbibed in the YouTube for a long time, and people can always go for watching this. The management of anaphylaxis, it can come as a short case also, or it can come as a theoretical question also. So many, I think, uh, options will be there in the theory and practical part, in the Viva part also. Dr. Madhuri, want to add something?
Yeah, Dr. Sudhir, suppose you are confronted with a pregnant patient. Your case was a case of anaphylaxis in pregnancy, right?
Yes,
So suppose you have a pregnant patient who tells you that she's got an allergy to local anesthetic lignocaine, and you have to give her labor analgesia. So now what will be your plan of management? Suppose she gives a history that she is allergic to lignocaine. Okay. Now you have to give her labor analgesia. So as per whatever your slides, you said that you have to avoid the triggering agent. So lignocaine is going to be a trigger here. So you have to avoid. There is no question. Now, how are you going to provide labor analgesia to her? Go on telling, don't get scared. This is how the exam viva will go on. Yeah, I will add.
Intrathecal opioids may be also used in
Intrathecal opioids, you will give her a chance. Okay, very good. Fentanyl. Okay. Anything else? Now the allergy to lignocaine. Have you heard about cross reactivity amongst
Yes.
local anesthetics? So can you tell us something about that? Now, if the patient is allergic to lignocaine, what is lignocaine? Which group of local anesthetics does it belong to?
Belongs to amide group of
Speak
local.
loudly. Amides.
It
Amides.
belongs to
Isn't
amides.
it? Amides. The other group is what? Esters.
Esters.
Esters. So that means there can be intergroup or intragroup cross reactivity to the local anesthetic. Intragroup or interclass also is possible between two different classes, but most common is intragroup, in the group, that is in the amide group, right? So it is likely that the patient, so can you use bupivacaine in this patient for labor analgesia? You should have said that bupivacaine is the common drug used for labor analgesia, isn't it? So even if the patient is allergic to lignocaine, could you use bupivacaine in this case?
No, ma'am, because it also
Why
belongs to
not?
amide group.
Yeah, so there can be cross reactivity. Yes. So what option will you give now then? But you have to provide the analgesia now.
Patient is allergic to amide group, we can go for ester.
Huh? Non-local anesthetic technique you will go for. That is already told, intrathecal opioid. Anything else? You can try for non-amide local anesthetic, like
Esters, chlorprop.
which local anesthetic can be used for labor analgesia? Epidurally. So the patient opted for chlorprocaine. You can use, na? Any other mode you can think of giving? Yeah, ropivacaine.
Tetracaine.
Somebody's written ropivacaine. But ropivacaine is an amide or an ester?
Amide.
Amide. Okay. Then you can also
Tetracaine.
try. Huh?
Tetracaine we can. Tetracaine
If
is
I,
also an
yeah,
ester.
if I give you remifentanil also, then you can use opioids, na? You can give intrathecal opioids, epidural opioids. You can use remifentanil, patient-controlled analgesia. You can give. You can give Entonox.
I can,
All other
now
methods you can
I will
use.
help Sudhir. I will help Sudhir. It's a viva going on for Sudhir. Sudhir, see, if a local reaction comes to any local anesthetic, now in the current day scenario, I think better not to use any local anesthetic. You go for the general anesthesia or something else. Rather, because we are not comfortable, we are not used to the other local anesthetics, the alternatives, as if we are using them daily. We are not using them daily. So, if it's a more sensible thing that if something is allergic, there may be many choices, but I think you should go to the thing which is most comfortable for you. Even if examiner asks, you say this patient life is more important rather than me experimenting with other drugs or other techniques. So whichever the most safest technique will be available with you, the GA, I think that go for that. In the current day scenario, so when you grow up to the age of Dr. Naveen sir, then you can go with any experimentation, but not at this stage. So you can answer this like, if Dr. Madhuri comes as external, just tell her this thing, she will give you a gold medal. So I think that is a good thing, way to go out.
There are some more questions in the chat box, Yashaswini.
Yes, ma'am. So, by Dr. Ravikumar, ma'am, Takotsubo after anaphylaxis.
What is that?
Takotsubo after anaphylaxis, ma'am.
Takotsubo cardiomyopathy.
Yes, ma'am.
Can you elaborate on this, Dr. Shalia? Anybody?
It is a left ventricular systolic dysfunction. It may occur to overdosage of adrenaline, and it is reversible also.
Very
It
good.
is hypokinesia, akinesia of left ventricle.
Excellent.
We have one more
I want to
question.
highlight.
Yes, sir.
Okay. After question, I will talk, madam. You continue with the question.
Yes, sir. By Rupanugadi Vijay, anaphylaxis during regional anesthesia and use of lipid infusion.
More of
Yes, sir,
a
you
this
can continue.
local this lipid infusion. It's mainly for the over toxicity. The, when the gout, when it's gain access to the vascular compartment, that lipid is
Last,
basically to bind that. It may not
last.
prevent the ultimate anaphylaxis for that particular patient. Lipid is mainly the binding agent for the local anesthetics. It can decrease the concentration, thereby preventing the ramification of the anaphylaxis. But I think you have to side by side go for the treatment of anaphylaxis along with the lipid infusion if such is the case. Because you may not be knowing whether it's anaphylaxis or it's the reactions of the local anesthetics toxicity. So you have to do the dual treatment rather than just relying upon the lipid infusion.
We have one more
Yeah,
question, sir.
I'll just add to that. That's what sir said is very, very correct. That last and anaphylaxis can always occur after giving a local anesthetic, and it's very important to differentiate between the two. So in the last, the CNS features will be very, very prominent. Okay, whereas in anaphylaxis you will not get these symptoms related to the CNS. Yeah, please proceed.
Yes, ma'am. Another question by Dr. Usha Kumari, ma'am. Is it mandatory to do drug allergy test before surgery?
That's a good question actually. I think it's difficult for Sudhir and Gautami because see drug allergy, at least the role of the, which I told in the beginning, the family history, the personal history of any allergy, that is very, very important because you going for the drug allergy in every patient, that's not feasible, that's not practically feasible in any of the setups. But if the patient gives the history of allergy to any drug, any substance, or any other thing, or is a family history of allergy, I think it's better always to go for the drug allergy. And I think even for the particular drug causing the allergic test, you may not get the anaphylaxis immediately. There has to be has a definite, the level of the allergens in the body, the antibody and antibodies also, the level of antibodies you can also test. Those are the preventive measures, those are the screening methods also. But with a simple history taking is very, very important in such cases. That will give you a clue to something.
One more question by Dr. Kondareddy, sir. Management of protamine-induced anaphylaxis.
Why Sudhir and Gautami silent?
Sir, in case of anaphylaxis, the first drug of choice is adrenaline, sir.
Shalia, when you say the answer, always tell me the dose, what type of
If,
toxicity, how it is occurring, and how the dose is administered. That is very, very important in telling the
sir, if the
answer.
patient is in anaphylactic shock, we need to go with the IV dose, sir.
Okay.
Only with
Yes.
the cutaneous symptoms like anaphylaxis, we'll go with the 0.5 mg at deep IM. On the anterolateral part of the thigh, we'll go, sir. Because there will be earlier absorption if we go with the anterolateral part of the thigh, deep IM, sir. Whichever drug may be the cause of the anaphylaxis, first drug agent of choice is the adrenaline, sir. If at all patient is in the hospital premises, like in the operating room or like that, if the patient is having secured IV line, we'll go with the IV, sir, adrenaline. 10 to 100 mics IV first we'll give, sir.
Yeah, that's the way to answer the thing. Good. So Shelia is doing very, very good now as a consultant in the hospital. Great, Shelia. Thank you for
Thank you,
that
sir.
answer. There's another question like use of preservative-free ketamine or subarachnoid block for lignocaine sensitivity for labor. I think if you ask me honestly, my view may not be the books may not agree to that. But when we are treating the patient in labor, we are dealing with two lives. And that is one of the most important tasks. And those are not patients. These are normal physiological human beings. They are not suffering from any disease. It's our responsibility also to use the drugs which are widely established for the use in labor analgesia. And majority of the labor people who are going for labor analgesia, they are very well aware of the effects of the drugs. They know about the labor analgesia. They are always, majority of them are intellectual people going for the labor analgesia, provided that some research project is going on in any institution about the labor analgesia. So when they are already given that choice, then they're already told about the allergy and about the side effects or after effects. The patient consent at that time is very, very important. Not patient, the parturient consent, as well as the consent of the husband and the family member is very, very important. You have to tell them, and the history of allergy is there. Definitely, you have to avoid these type of things. But somebody said Antonog, somebody said other thing. I think now we had a one international workshop on TCI TIVA, and there was a one workshop about the labor, this one obstetrics, TIVA, TCI in obstetrics, analgesia also. So I think that is the way to go forward with the advancements and so many things happening. The TCI TIVA is another way of having the labor analgesia. Very soon it will be in the proper format in the books. So again, I think when going for the labor analgesia with the allergic things, you have to be very careful because any harm done to them will reflect upon your capability, your skill, your sincerity. So you have to be very careful, I think. And I think these cases have to be done only if they have allergy to the anesthetics. They should be in a tertiary care centers where all the facilities to revive them should always be available. These are very simple rules for labor analgesia. If they are followed in entirety, I think we can always escape the medico-legal aspects also later on.
Yes. I think Dr. Naveen sir wanted to say something.
Unmute, sir, unmute.
I want to tell a brief about the case we have encountered. The case is actually posted for the elective cesarean section. Before shifting the case to OT, they have instituted antibiotic, preoperative antibiotic. After starting of antibiotic, patient develops severe anaphylaxis reaction. Patient developed immediately chest pain, severe breathlessness, no radial, and BP was not recordable. And patient when came to the OT, her saturation was only 70%. The slide they have PG have forgotten to keep. Only 70%. The pulse rate was 140 to 160. So we thought that the patient is very unstable. We thought general anesthesia very high risk in this case. What we have done 100% oxygen with polymers. I have instituted routine protocol treatment of anaphylaxis and given only landmark technique of tab block. And we have done emergency, started the emergency section. Both mother and child have survived this case, sir. I think every PG should learn to give the technique of tab block in very, very risky cases of cesarean section. If all PGs learn the technique of tab block, we can save many pregnant women, sir.
Yeah, it comes very handy in cases of, when they land up to these type of crisis situation and ASA 3 patients also pregnant. And even in I think the regional techniques, the only limitation is the availability of the ultrasound in your settings. If it is available, I think better to go for the regional blocks. You can always save the patient. You at least, the effect is localized to a region, not to the systemic effects. I think that's a way to go in the future also. But considering the PCP and DT Act, very soon we are going to have this white paper presentation to the government of India through the NMC also and with other organizations, the PCP, so that the anesthesiologist can use this ultrasonography more widely for the regional anesthesia in India, uniformly, because in many states they are very strict in this act where you can't take the ultrasound from one place to another, one room to another. So I think we have a webinar on 4th of November where we will be having the government agencies also there to present that paper, white paper to the government of India, where we can really push the regional anesthesia to the another level in India. That is going to happen very soon. So do switch over to your this one screen on. I will be sending that link and messages to almost every group of ISA. You can log into that particular webinar and see what's really happening, how we are pushing the regional anesthesia and ultrasound to the next level. So that is very, very important. So there is a one question for Sudhir and Gautami. How to treat accidental intravascular injection of LA? I think you can easily do
First,
that. So that's not an issue.
first we need to stop the further infusion of the local anesthetic drug, sir. Then we should call for help, and it consists of three components, sir. Last management. One is we should keep ready the 20% intralipid emulsion, sir. And second thing is should have ventilatory support and cardiovascular support and seizure control, sir. So hypotension, bradycardia should be treated accordingly with vasopressor, sir. And seizure, if patient is having seizures, then we can give adjuvants like midazolam, sir. And we shouldn't give propofol, sir, because it itself causes hypotension. So we can treat the seizures with benzodiazepines or midazolam. And if patient has unconscious poor GCS, we should intubate the patient, and the airway should be secure. And we should give intralipid emulsion, sir. Initially 1.5 ml per kg bolus, followed by 0.25 ml per kg per hour.
So before we move forward, I will just like to felicitate our faculty on behalf of our ISA National. Dr. Madhuri, my screen is visible? You are muted.
Yeah,
So,
we can see your screen, but
yeah,
we can see your screen. Yeah, there's some black thing
yeah.
in the side.
Is it coming, not coming uniformly?
It's coming, but there are some black ribbons, black bars on either side, up and down.
Okay,
But it is seen. No problem.
okay. So, Dr. Naveen sir, thank you very much for the wonderful efforts for conducting this class and preparing your team and doing a very, very important topic. Now, this important topic has become the what you call the property of ISA National now. So it will be keep on people can keep on viewing this topic on the ISA NHQ at YouTube. So you can always see the comments on the class coming. Many people may not have been able to log in, but they will keep on listening to all the treatment patterns and modalities when they keep on watching. Thank you, sir, for preparing your team, sir.
Okay, thank you. We are looking for another opportunity, sir, shortly.
We will do, sir. We will give. And
Okay.
Dr. Jagdisha Charlu, sir, thank you once again for being the, co-moderator and preparing the students for this class.
Thank you, sir.
And Shelia, you have always been energetic as you were right from the last 4 5 years. So you're doing a wonderful job now as a consultant. So thank you for being with the PGs. I know you are more in contact with the PGs, preparing that I also. Thank you, Shelia, for being a wonderful moderator in this class. And Sudhir, yourself, as well as Gautami, I think you did good answering and you just escaped the gold medal from Dr. Madhuri because that question you could not answer to the last part. Otherwise, the gold medal could have been yours. But we know that you in the final you will be able to get if Dr. Madhuri comes as an external. So that is another way of going forward. And Yashaswini, you held up the one end of the fort of moderating. Thank you very much for being the screen coordinator for this class.
Thank you, sir.
And you did in a wonderful time. And you, in spite of your duty schedule, you came to the PO. And Saranya also, she could not do it, because of some issue, but she was very much there during the preparation of this class. So thank you, Saranya, to you also. So that was our felicitation ceremony. So thank you very much for the team. And you rightly deserve some one more opportunity, and we will soon come back to you with another opportunity very soon. So any other comments or want to suggest some feedback before we say goodbye to the class?
Sir, please concentrate on the practical problem. Don't insist on theories, sir. They can read from the textbooks, all those things. Try to focus more on the practical problem.
Yeah, you're right, sir. If you see the last 2 year classes on the YouTube, you will come to see that all the practical things are being discussed now, and that too in a real classroom teaching where the PGs are presenting the what I can say with the more heartening way is that many PGs of India they are getting more confident now because almost from every college we have got the PGs who have presented the class, and it's very infectious. The other PGs around them also feel very secure that we are now able to get to any examination because this is a national examination for them. Anybody is asking the freestyle any question to them and they are answering it. So that is instilling a confidence. If you really compare throughout the globe, how many PGs inside throughout the globe will be able to answer with that much confidence, which our Indian PGs are giving in such a good way? I think, sir, that's more because the class, the crux of the class is to have a very practical discussion. Theory part is important because the PGs have to appear for theoretical examination also. But discussion is mainly always oriented toward the practical parts. Practical and some feasible parts which even the examiners, they always ask in the examinations. So, sir, you can always see the classes. Our endeavor is to have more of a real life practical situation because after passing out, these PGs will be facing either as a senior resident or as a practitioner or the corporate setup. So they should be prepared in that way also. So that is the main goal of these classes, sir.
On
Shailya,
behalf
you want to
of
say?
our department, I thank you so much, sir, for giving this opportunity, sir. You and
Yeah,
Madhuri, ma'am, thank you so much, sir.
yeah, sir. And I always thank Dr. Madhuri, Dr. Nishant, Dr. Ridhima because they are the people who are the backbones who prepare the classes, the technical aspects, and it goes so smooth. So there is hardly any, lacuna in the classes. If somebody is not there, the other person is there to build it up, to make it up. So I'm really thankful to my team, and we have done a good work over the last 3 years. I'm really proud of my team also. Nishant, you want to say something?
Nice, sir. Thank you so much. Today's class was really nice and a very, very important class on anaphylaxis. They have covered each and every aspect. The questions that come to mind, most of them have been answered. Very
Yeah,
nice.
yeah, true. That's really thing. I think we are done with. So it's time to say goodbye and good night. Till we meet coming Monday, we will be having a class. Monday or Tuesday, most probably. But कोशिश करेंगे कि Monday हो class. Anyway, till then, goodbye, good night, and long live ISA.
Long live
Long live
ISA.
ISA.